It's draft 5. So, with all your due permission, we are beginning with the session for today.
Oh, yeah.
Good evening, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session, Thomas Sir. Sir is MBBS, Diploma in Tuberculosis and Chest Disease, MD in Tuberculosis and Respiratory Diseases Medicine, Senior Consultant Pulmonologist at Sri Ramachandra Medical College and MGM Healthcare Hospitals at Chennai. With Sir's enriching experience and with his wonderful insights, we are going to talk about the topic for today, which is what is new in gold 2023. Before moving on to today's session, let us have a brief look on what the topic says. So, in this insightful webinar, as we explore the groundbreaking advancements and latest features in GOLD 2023, the global initiative for chronic obstructive lung disease is at the forefront of respiratory health, and this year's updates promise to revolutionize the approach to COPD management. To talk about this topic, we have the expert with us in our forum. So now, without any further delay, I would like to welcome Sir and would like to hand over the session to him for his precious talk to begin. So over to you.
Thank you very much and a warm good evening to one and all. I thank IGCP for having given us the opportunity to get together on this platform. It's indeed a pleasure and a privilege. I consider it a great honor to be here. We'll talk today about what Gold 2023 has told us and what are the real updates as far as gold is concerned. We understand that gold is synchronous with COPD through the ages. And I think through the years that gold has been there for the past 5, 10, 15 years, we've known that it's synchronous with COPD and COPD management. And to a great extent, I think it has driven the purposeful management of COPD and the meaningful remission of patients from their diseases. It really means that it gives us an outline and a framework of how to go about proceeding to treat patients with COPD and the problems that we encounter thereof. But there are some key changes in Gold 2023, which we shall try and look at this point of time and see what best we can do under the circumstances. What has happened to this? Yeah. So COPD is a heterogeneous condition, characterized by chronic respiratory symptoms, cough, production of sputum in the airways. There is something that they've called pre-COPD, and I think that's very interesting in the sense that some individuals have respiratory symptoms and or structured lung lesions, but without airflow limitation. And I think this is a very important entity in the sense that you have people with respiratory symptoms who have respiratory symptoms and or structural lung abnormalities, but they have no real airflow obstruction when you get to the spirometry. And I think that's, again, very interesting in the sense that this is remarkably different from what we've been talking about for a very long time. The term PRISM, preserved ratio impaired spirometry, has been proposed to identify those with normal ratio but abnormal spirometry. Normal ratio, abnormal spirometry, they're at risk of developing COPD or airflow limitation over a period of time, but do not do them at all as we see them. So what are the other causes of chronic obstructive airways disease? It can be intrathoracic, asthma, lung cancer, tuberculosis, bronchiectasis, left heart failure, interstitial lung disease, extrathoracic being rhinitis, postnasal, the PNDS syndrome, the USC has upper airway cough syndrome, the gastroesophageal reflux, medications, ACE inhibitors. And I think this is probably one of the most important changes that we've seen in Gold 2023. the fact that they have subclassified and subsegmentalized the types of COPD that we're dealing with. So genetically determined COPD is called COPD-G, which is alpha-1 antitrypsin deficiency. COPD due to abnormal lung development is called COPD-D. Then environmental COPD, of course, you have cigarette smoking COPD, which is called COPD-C. Biomass and air pollution COPD, which is called COPD-P. And then COPD due to infections with COPD-I in childhood infections, tuberculosis, associated bronchiectasis, and COPD and asthma overlap, especially, I think, particularly childhood asthma. An unknown cause of COPD has been put down as COPD-U. So what they have tried to do is at a single glance, you try to know what COPD is. So far, COPD has a lumped up diagnosis where all the types of COPD, whether you call it post-tubercular COPD, whether you have post-bronchiectatic COPD, whether you have air pollution COPD, whether you have smoking COPD, whether you have non-smoking COPD, you dubbed all these things together. But today, I think with a single suffix, I think, they have really segmentalized the COPD and super segmentalized it and made it very, very interesting for us to try and practice as clinicians as we go from it. Chronic bronchitis. They've got back this term chronic bronchitis. Now, chronic bronchitis has been lost in literature for quite some time. It's defined as the presence of expectorant sputum on a regular basis over a period of time. Prevalence ranges from 27 to 35%. Those at risk of chronic bronchitis have the risk of developing COPD in these patients. Gastroesophageal reflux is also associated with an increased incidence of chronic bronchitis, and radiographic manifestations of mucus plugging may be present and persist in patients with COPD despite a lack of chronic bronchitis symptoms, and is associated with greater airflow limitation, as we'd like to know it. Lower the oxygen saturation, worsen the quality of life. But I think this is the most important change that they have really looked at in these patients with COPD. If you look at the change, I think that's the change that we're really looking for. So far, we've looked at the assessment of airflow limitation, where we looked at gold, the FEV1 predicted being 80%, 50 to 79%, 30 to 49%, and less than 30%. Then, of course, you had an exacerbation history of greater than 2 moderate exacerbations, or greater than 1 leading to hospitalization, moderate exacerbations not leading to hospitalization. They have done away with the subclass of C that we're looking at, and they've put it down as A and B, and they've classified this as E as such. E refers to the severe COPD. A and B refer to the smaller types of COPD, which are not that severe. And I think it's very, very important, because we thought that C was a subclass where nobody really knew what was happening in C. You were neither here nor there. You were neither severe nor you're not severe. So it was a very confusing subclass, and they've done away with the C. And now they've called it A, D, and E. You can call the E exacerbations if you want, or you can just follow the tegmental ABCD phenotype as such. But I think it's important for us to understand that the phenotypes are important, and then we can see what we can do. 1 minute. See on this. So we have A, B, and E, not A, B, C, and D. And I think greater than 2 exacerbations, you have group E, where you have LABA-LAMA. Consider LABA-LAMA ICS if blood eosinophils greater than 300. And I think that's very important. We'll come from the top. We'll come from group E and say that you consider LABA-LAMA ICS, especially if you have a blood eosinophils of greater than 3000. So E could mean eosinophils. E could mean exacerbations, because this is a group that exacerbates very frequently, and you will find them going into hospital and coming out very frequently. Group A, of course, would be a bronchodilator, and group B, of course, would be a LABA-LAMA in these patients. And I think it's characterized by exacerbations on one side and the MRC and the CAT score on the other side. So this makes it a much better and a more defined explanation of the way that we're looking at patients with COPD. And I think we need to understand the fact that COPD by itself, I think, is something that has gone through profound changes over a period of time. and hence we need to understand the real implications of what we're looking at. So looking at diagnosis, you're looking at adjustment of initial symptoms, the gold 1 and gold 4 symptoms of CAT or MRC, exacerbation history, smoking status, alpha-1 antitrypsin, and the gold which says it's ABE. Then, of course, you review these things, and then you initial management of smoking cessation, you give vaccination, you give bronchodilators, start them on the initial assessment of COPD. Then you go back and review your patients with COPD and find out how they're smoking, review their smoking status, exposure, other risk factors. Inhaler technique and device are very, very important. For the first time, I think Gold has come out with a section on inhaler techniques, which I think is so important in patients with COPD and asthma. The need for oxygen, NIV, lung volume reduction surgery, palliative approaches, vaccination, and the management of comorbidities. And then you try and adjust the pharmacotherapy and the non-pharmacologic therapy. And I think so we've got a real nice distribution in the flow chart, which starts with the diagnosis, go to the initial assessment, then you have the initial management. And once you get the initial management going, you go through a section of review, and then you try and adjust your therapy as such. So the Emax that is randomized in these patients who had umeclidinium and salmeterol as such, and given the trough FEV1, and we very clearly understand that the triple drug therapy was much, much better in these patients than the umeclidinium and the vilanterol that we've really looked at. So the umeclidinium vilanterol is much less preferred, especially as far as exacerbations are concerned. And also tying to the first exacerbation in these patients, you find the onset of triple drug therapy, which has become extremely important. So we now clearly understand that the triple drug therapy, there are two triple drugs which are very, very common, very commonly used. First, of course, would be fluticasone furoate, umeclidinium and vilanterol. And the other, of course, would be mometasone, indacaterol, mometasone, indacaterol, mometasone, indacaterol in these patients. And I think we need to look at it that way. We look at these patients with these drugs as we look at it. So I think we're looking at the triple drug therapy, which has come to stay, be it exacerbations, be it death from any cause in these patients. We find that triple drug therapy has really come to stay. So triple drug therapy is classically indicated, especially when you're getting down to group E, for example. You understand that the ICS-LABA, that the LABA-LAMA is not working. You need the ICS. You need the ultra-LABA and the ultra-LAMA in these patients. So you use umeclidinium, fluticasone and vilanterol, or you use mometasone, indacaterol, and glycopyrronium, as the case may be. So if no response to initial treatment is appropriate, maintain it. If response to initial treatment is appropriate, maintain it. If not, check adherence to inhaler therapy. Then you have two streams as such. The first stream would be the dyspnea stream, and the second stream would be the exacerbation stream. If you have a dyspnea stream, then you look at the LABA-LAMA or the LABA-LAMA ICS. Consider switching inhaler device or molecules, implement a non-escalate, non-pharmacologic therapy like pulmonary rehab in these patients when they have a lot of dyspnea. If you have a lot of exacerbations, of course, you look at blood eosinophils. If your blood eosinophils are in excess of 300, you're a very classic candidate for triple drug therapy. And after that, you switch over to drugs like roflumilast and azithromycin, preferentially in former smokers in these patients. So they have produced two clear tracks, one track concentrating on the dyspnea and the other track concentrating on the exacerbations. And we understand that there are a lot of implications between these two groups. Single inhaler therapy may be more convenient and effective than multiple inhalers. Consider de-escalation of ICS if pneumonia or other considerations are to be made in these patients. So for patients under treatment with ICS plus LABA, yet if the patient has had a further exacerbation, treatment should be escalated to ICS LABA-LAMA. By major symptoms, switching to the LABA-LAMA should be considered. So you look at factors to consider when adding the ICS to long-acting bronchodilators. Note that the scenario is different when considering ICS withdrawal. strongly favors the use of this, which is history of hospitalization and exacerbations, which strongly favor triple drug therapy. Blood eosinophils we've already seen in excess of 300. History of concomitant asthma, and we have favors the use, of course, would be one moderate exacerbation of COPD in the blood eosinophils of 100 to 300. And against, of course, would be the fact that you get pneumonia in these patients as such. So the diagnosis and the suggestive features of COPD asthma, you look at the differential diagnosis, I think this is very interesting in the sense that asthma is, of course, stands out at the first differential diagnosis. Look at congestive cardiac failure, look at bronchiectasis, look at all other problems, look at tuberculosis. Bronchiectasis is a very, very important condition today that can produce very fluctuant COPD with patients exacerbating and remitting very quickly, going into hospital and coming out. And I think we need to very clearly understand that these patients, it's very, very important to consider this in these patients as such. So diagnosis would be suggestive of all ages chest X-ray showing lung infiltrate, microbiologic confirmation, looking at obliterative bronchiolitis and diffuse panbronchiolitis in these patients. So what is the definition of an exacerbation? Exacerbation of chronic obstructive pulmonary disease characterized by increased symptoms and a cough and sputum that worsens in about 10 to 14 days, may be accompanied by tachypnea and tachycardia, often associated with increased local and systemic inflammation caused by infection, pollution, or other insult to the airways. So we understand that this is an exacerbation in symptomatology, which is accompanied either by an infection or by a non-infection. Sometimes you can have a non-infective exacerbation, in which case it may be attributed to smoke pollution and things like that. You could have an infective exacerbation, which may be coming out from a patch of bronchiectasis or a secondary infection or sepsis or some other infection that is percolating through this. So complete and thorough clinical assessment for evidence of COPD and potential majority and non-respiratory concomitant disease. Assess the symptoms. Severity of dyspnea can be determined by using the vasomotor score and documentation of the presence of cough. Evaluate severity by using appropriate additional investigations like pulse oximetry, laboratory assessment, CRP, and arterial blood gases. So I think the CRP is a very important entity in these patients, especially when you want to identify infections, especially if you want to differentiate between bacterial and viral infections. Arterial blood gases are very important because patients with COPD have compensated hypercapnia, where you think that the hypercapnia is compensated. The hypoxia they have tolerated hypoxia, permissible hypoxia, as we like to call it. And then we have established the cause of the event, be it viral, bacterial, or environmental in these patients. Recently, evidence has emerged from two large randomized trials of the impact in the ethos that fixed dose inhaled triple drug combinations of LABA/LAMA ICS reduce all-cause mortality compared to the dual long-acting therapy of bronchodilation. This is what we said when we talked about triple drug therapy. We understand today that triple drug therapy has come to stay, especially in COPD-E compared to COPD-A and B. And then, of course, it's accompanied by non-pharmacologic treatment, smoking cessation, pulmonary rehab. Long-term oxygen therapy continues to play a very vital role in these patients. Non-invasive positive pressure ventilation, lung transplantation, lung volume reduction surgery, as we'd like to look at it. So evidence of smoking cessation, I think this is stating the obvious. We understand very fully today that smoking cessation is one of the main important things that we look at in these patients. And for a very, very long time, we have felt that the only entity that plays a very clear and discriminating role in the sense of reducing COPD mortality is smoking cessation. Nothing else really comes anywhere close to smoking cessation. So I think this is an extremely important thing. So CDC recommends the use of the 20-valent pneumococcal conjugate vaccine, or PCV20. In our country, of course, we have only the 13-valent and the 23-valent vaccines that we use. 15-valent pneumococcal conjugate vaccine, PCV15, followed by 23. Now, this, of course, is a recommendation that comes out of Europe. and comes out of the rest of the world. But in our country, we have only PCV13 and we have PCV13 and we have 23. And then, of course, we have the influenza vaccine, which is the quadrivalent influenza vaccine that you're looking at. Arterial hypoxemia, when do you give oxygen in these patients? It's a very interesting question in the sense that very many patients with COPD are denied oxygen. And delayed oxygen is denied oxygen. And I think that's really what is important. Arterial hypoxemia is defined by a PaO2 of less than 55 or an SaO2 of less than 88, PaO2 55 but less than 60 with right heart failure or erythrocytosis for that matter. So it's not only the question of percentage of the SpO2 that you're going to look at in these patients, but it's also the fact as to whether they have a right heart component at all or not. Do they have a right heart component? Do they have a lung component, which includes bronchiectasis and look at structural lung diseases? You recheck in about 60 to 90 days to assess if supplemental oxygen is still indicated. If prescribed, you can continue to take them. So issues related to inhaler therapy, inability to use the delivery system correctly. We talked about at the beginning itself that for the first time, Gold and Gina have talked about inhalation therapy and have talked about the use of inhalers, the correct use of inhalers, how to really use them over a period of time, ability to use delivery systems correctly, selection of the right patient, using the teach back approach, patients being asked to show how the device has to be used, appears to be particularly effective, pharmacist, physician, physiotherapy, and nurse-led interventions, as well as lay health coaching can improve inhalation technique and adherence in patients with COPD. As in asthma, digital inhalers could contribute to improve compliance as such. The selection process should aim to identify the optimal device for each patient. There is no best device for a patient. No, there is only an optimal device. Every person is optimized to receive a type of device, and I think it's up to us to find out what is the best optimization that we can achieve in these patients so that they can be treated with the right type of inhalers and get the right attitudes in this. If a new device is required, either because the patient is not using the current device correctly or the drug is not available in the same device, a systematic approach should be made to select a delivery system and ensure that the patient can use it. So the basic principles would be availability of the drug in the device, patients' beliefs and satisfaction, the fact that you need to convince patients that inhalation therapy is best in these patients because we're dealing with an airway problem and your inhalation goes only into the airways, does not go anywhere else. The number of different devices should be minimized for every patient. Device type should not be switched in the absence of clear clinical justification. There would be no point from switching to one device another under the guise that one device is superior to the other. Shared decision making is the most important strategy for inhalation devices. Try and demonstrate a couple of inhalers to patients and get them to use some sort of shared decision making process, because if you have shared decision making process, you have shared responsibility for compliance. There is a shared responsibility both with the patient and the doctor, and the compliances. The compliance will be much better. Dry powder inhalers are appropriate only if the patient is able to breathe deeply and forcefully. Metered dose inhalers and soft mid inhalers require coordination between the device and triggering mechanism. To use a patient with an MDI, of course, with a metered dose inhaler, you need to use a spacer in these patients. Other factors to consider include size, portability, and cost. Smart inhalers may be useful if there are issues with adherence, persistence of inhalation, and of inhalation techniques. Physicians should prescribe only devices, and other members of the caring team, they should know how to use them at all. So patients' beliefs and satisfaction, the previous devices, the number of different devices should be minimized. In the absence of clinical justification, without proper dry powder inhalers are appropriate only if patient can take a forceful and deep inhalation. Check visually that the patient can inhale forcefully through the device. If there is any doubt, assess objectively or choose alternative medication. So the defined use of CT scan, for example, this is another thing that they've really talked about today. The CT is such a very commonly used investigation in patients with COPD, and it's such a useful investigation, especially when you want to pick up small airways disease, when you want to pick up hyperinflation, when you want to pick up Bullous disease, when you want to pick up bronchiectasis. And I think it's very important. So the differential diagnosis would mean frequent exacerbations with cough, raising concerns for bronchiectasis, as I said, or atypical infections. When you're looking at things like lung volume reduction, endobronchial valve therapy as a therapeutic consideration for patients who exhibit post-bronchodilator FEV1 between 15 and 45 and hyperinflation, lung volume reduction surgery suitable in patients with especially apical hyperinflation, severe upper lobe predominant emphysema, and inadequate exercise capacity. Lung cancer screening, annual low dose CT scan. Now that's a different matter altogether. I don't think we'd go into it. It's a controversial subject, and especially in a country like India with its mass population and the logistic problems that we're facing, we really don't know if lung cancer screening is a viable option considering all the infective diseases that we're really looking at in these patients. So the prevalence of computed chest tomography to assess patients, especially with comorbidities, emphysema, bronchiectasis, interstitial abnormalities, coronary artery disease, pulmonary artery embolism, descending aorta enlargement, hiatal hernia, stenosis, osteosteatosis, osteoporosis, and low PSSD. Systematic detection of 10 CT-guided comorbidities, most of which were not detected clinically, provides information of potential use to patients and clinicians. So far, a CT scan has been used in situations where you suspect something else. Today, I think CT scan itself can throw things at you, which are hyperinflation, which are bronchiectasis, which are Bullous disease, all these conditions, interstitial abnormalities, bronchiectasis, emphysema for that matter. So I think these are things that the CT scan can throw at you and give you valuable information as to how you can go about expanding the aura of your therapy, or expanding the range and the reach of your therapy to try and see what evidence it produces. Non-pharmacologic therapy, treatment effect on mortality, triple versus dual, relative risk of impaction. Non-pharmacological therapy means smoking cessation, pulmonary rehabilitation, long-term oxygen therapy, LTOT, NIV, and the LVRS, which is the lung volume reduction surgery. Lung volume reduction surgery is only meant for a few select patients with apical emphysema and apical hyperinflation. NIV is a very important entity in these patients, especially patients who are very sick. The nocturnal NIV does a lot for them to wash out the carbon dioxide they're having accumulating over a period of time. And we need to understand that this is a very important entity. Oxygen, I think, is a matter of excellent priority in these patients, because the sooner you use oxygen, the sooner you reduce the hypoxia, and the sooner I think patients become better. Smoking cessation, I think we've already talked about smoking cessation. So pulmonary rehab improves dyspnea, health status, exercise tolerance. Pulmonary rehabilitation reduces hospitalizations, reduces exacerbations, reduction of anxiety and depression. Education and self-management. Education alone is not shown to be effective. Self-management intervention, patient communication with a health professional improves health status. Integrated care programs and telehealth have demonstrated no benefit at this point of time. But today, I think after the onset of COVID, there's been a huge resurgence of teleconsultation and telerehabilitation for that matter. There are telerehabilitation courses that patients can undertake, and these have helped a lot of these patients in many ways. And I think the COVID pandemic, I think, has opened up a huge aura of a Pandora's box of patients with priorities which can be prioritized and used as far as tele-rehab and things like that are considered. So I think tele-rehab and a teleconsultation, I think, are important entities in these patients, and I think we need to use them. And over a period of time, I think we'll get to a situation where if you can incorporate AI, for example, into this could be a huge matter in the future as we look at these patients and as we look at the anxiety and their depression as such. So telerehabilitation has proved to be an alternative An even more relevant COVID pandemic era where in-person PR is not being feasible. In the field of rehabilitation, standardization of delivery platform, no single best mode of telerehabilitation delivery, tests performed remotely allowing for accurate exercise prescription, information of suitable variations in components and timing of intervention without any data available regarding post-exacerbation rehabilitation. Evidence about duration of benefit studies have suggested telerehabilitation is safe and has similar benefit to those of center-based rehabilitation in these patients and outcome. So the overview of current surgical and bronchoscopic interventions for people with COPD, symptoms, chronic mucus, exacerbations, and dyspnea. We look at disorders which are chronic bronchitis, acute bronchitis, bullous emphysema, tracheomalacia, bulla, emphysema, and tracheomalacia by itself, surgical and bronchoscopic interventions which include nitrogen cryospray, rheoplasty, targeted lung denervation, giant bullectomy, large airway stenting, EBV, the coil, the thermal vapor ablation, lung sealants, LVRS, and lung transplantation. These are the sort of end of frontiers of science as such in patients with COPD, where I think science has improved to such a great extent that we go and try and relieve or remodel the structural abnormalities that we have in COPD so that we have lasting benefits in these patients and patients are benefited to a greater extent with this. Bullectomy, effective approach for surgically removing bullae, lung volume reduction surgery, more expensive than healthcare plans without surgery, physiological and functional improvement with LVRS, lung transplantation. There are thousands of patients today undergoing COPD lung transplantation. Patients with progressive COPD should be considered for lung transplantation. In transplantation, I think the most important entity in transplantation is to time your transplantation properly. Too early or too late transplantation is really not going to help. So the question of timing the transplant is very important. Making sure that you look at the entity where when you transplant, you have good other organ systems which are functioning very well. Look at the age, for example. Younger the age, better the outcome. Lesser the comorbids, better the outcome. So I think we need to look at all these things and put all these things in a box and look at the considerations that all these things will produce multiple benefits in patients with COPD as we see them today. So excessive airway dynamic collapse, nitrogen cryospray, we talked about lung denervation, bronchoscopic interventions due to mobility and mortality associated with LVRS, less invasive bronchoscopic approaches to lung reduction have been examined. These include a variety of different bronchoscopic procedures to perform lung volume reduction, endoscopic lung volume reduction, ELVR, including airway bypass stents, endobronchial one-way valves, self-acting coils, and sealants. We look at a lot of these things. So the overview of bronchoscopic interventions would be looking at symptoms, chronic mucus production, exacerbations, and dyspnea. We've already talked about acute and chronic bronchitis, bullous formation, and tracheomalacia, giant bullectomy, and the rest. So greater focus on management of patients with chronic bronchitis include the overproduction of mucus, decreasing mucus hypersecretion by reducing inflammation. So and this is another entity that they've really transposed on. They would have looked at mucus hypersecretion and called it a very important entity in the treatment of patients with long-term COPD, and especially the chronic bronchitic phenotype. Facilitating cough mechanisms, smoking cessation, mucus clearance treatments that promote mechanical movement through the airway, such as oscillating positive expiratory pressure, could be maybe used to mobilize the sputum and bring them out. New classes of mucolytic agents like incenticaphtor. So I think new bronchoscopic interventions have been proposed to reduce mucus hypersecretion in patients by eliminating the goblet cell hyperplasia and the submucosal glands. So frailty and polycythemia, these are two new comorbidities that they've developed. A lot of our COPD patients belong to the frail phenotype. We call them the chronic bronchitic phenotype. Frailty can now be defined as the presence of 5 components: weakness, slowness, exhaustion, low physical activity, and unintentional weight loss. These are thin COPDs that we're looking at. Polycythemia has been long recognized as a common comorbidity in patients with COPD. Reported prevalence of 16 to about 10%, defined as hemoglobin of greater than 17%. The percentage of polycythemia is probably directly related to the long-term mortality and morbidity in these patients with COPD. In COPD, secondary polycythemia is present. A careful evaluation should be made and performed to undermine and determine uncorrected hypoxia to rule out the presence of any comorbidities that require a specific infection. Anemia, periodontitis, and dental health, for example, these are multiple entities. Now, periodontitis and dental health will deal with nutrition. And I think that's very important. You have periodontitis, you have dental abnormalities, you have difficulty in swallowing, your nutrition starts going down. So nutrition is a very important entity in patients with COPD. And once you think that your nutrition has become negative, I think there could be a lot of these issues as such. Anemia is very frequent in patients with COPD. Whether it is due to the fact that you have chronic hypoxia itself, or whether it's due to the physiologic phenotype of the COPD that you're looking at. People with COPD and anemia are generally older, have more frequent comorbidity conditions, greater dyspnea, worse quality of life, and airflow obstruction, reduced exercise capacity, and an increased risk of severe exacerbations. So COVID-19 and COPD, we clearly understand today that the overlap of COVID-19 and COPD has not been a good combination. It has been a situation that has produced a huge amount of problems for us, especially as far as the structural lung is concerned. The fact that COPDs are greatly exaggerated by the fact that you have a concomitant COVID pneumonia over on top of that. Continue and maintain usual COPD therapy. Look at controlled oxygen, look at controlled oxygen early. Look at the antiviral therapies, for example. Look at the other modalities of therapy. COVID-19 has taught us a very, very big lesson that the comorbidity of COPD as such in patients with COVID pneumonia is a very classic sign of increased mortality and morbidity in these patients with COPD. So full review of all clinical and laboratory data when you look at discharge, check maintenance therapy and understanding, reassess inhaler technique, and I think again that's a point to understand. Ensure understanding of withdrawal of acute medication, need for continuing oxygen. I think this is something that we've discussed already. Provide a management plan for comorbidities and follow-up. Ensure follow-up arrangements, early follow-up at less than 4 weeks or a late follow-up less than 12 weeks. All clinical and investigational abnormalities have to be identified. So a summary of the key changes would be a new definition of COPD has been proposed. We've looked at A, B, and E. Chapter 1 has been rewritten to incorporate a new background information on COPD and new strategies. New section on chronic bronchitis has been added. Additional information on screening and case finding has been included. The ABCD assessment tool has been revised to the ABE assessment tool to recognize the clinical relevance of exacerbations independent of the level of symptoms. New information on imaging and computed tomography. Vaccination recommendations have been described, especially with the question of the pneumococcal vaccination and the influenza vaccination. Further information on therapeutic interventions to reduce mortality and COPD. A new definition of COPD, of exacerbation-related mortality issues related to delivery device. Tele-rehab, there's been a very, very good section on tele-rehab. Section on intervention and surgical therapies for COPD has been expanded. Information and figures outlining initial pharmacologic treatment and approach. The question of stressing on triple drug therapy, especially in patients in the COPD E group, for example. The topic of management of exacerbations has been expanded to include details of possible alternative causes of symptoms and a new table of diagnosis and management sections of COPD as such. So I think we've done and looked at a lot of changes in COPD, looking at the terminology of COPD, looking at the types of COPD that you're looking at the suffixes in COPD that you looked at COPD-B, for example, COPD-I, for example, COPD-O, for example. No, these are all subtypes that tell you that this is the type of COPD that you're looking at, rather than going into it and finding out upfront itself. You recognize that this is a separate segment of COPD that you're looking at, and you need to look at these things with a great deal of importance. So, ladies and gentlemen, COPD, I think Goal 23 has given us a good package as far as COPD is concerned. It's given us a wholesome package as far as COPD is concerned. It's looked at all entities of COPD and made it a wholesome disease for us to treat, so that when we treat patients as a whole, and we don't treat a single segment of pharmacotherapy alone, but we look at all the other things, including rehab and surgical devices and things like that. Look at comorbidities and look at all the other things that we need to do. Gold COPD will go a long way in trying to help us to treat our patients with COPD and help our patients lead much better and more active lives. Thank you very much for the patient listening, and a good evening to you all.
Thank you so much, sir. Thank you for such an enriching talk that you have shared on our platform upon this important topic that you have talked about. Thank you so much for that. With this, we have received few questions, sir, from the participants with all your
Please,
due permission.
please,
Yes.
please, please read out the questions. I'll answer.
The first question is, sir, what challenges or opportunities do you anticipate in implementing the new GOLD Gold guidelines in your clinical practice?
I think the entity as such, as far as I could see, would be three things. Would be two things rather. The first thing, of course, would be the fact that we need to be very clear about the COPD as such, and whether we are looking at an early COPD with early airflow limitations, we're looking at B and C, or whether you're looking at E. Now that could be that may not be a big challenge, but I think that's a very important entity. Differentiation is very important as far as E is concerned, and the fact that you need triple drug therapy in E, whereas you can do with a dual drug therapy in A and B as such. The other thing, of course, would be the fact that you're looking at specific diagnosis in these patients. So looking at bronchiectasis patients who have COPD. You're looking at post-tuberculous patients who have COPD. So looking at a lot of other things as such. So COPD has become a gamut and a mixture of entities as such, not only of different active devices, diseases as such, but also I think the question of comorbidities, like cardiovascular comorbidities, very, very important in patients with COPD. Diabetes, for example, obesity, for example, obstructive sleep apnea, OSA, for example. Now, all these things are built into COPD today. So, at comorbids have become as important as the disease of COPD itself, if not more important than that. And in many, many situations, attention to comorbidities by themselves would be one of the biggest challenges that I would face in these patients with COPD.
Thank you so much, sir. Thank you for answering that question for our viewers to understand it better. Moving to the next question that we have received, and the question is, what impact do the Goal 2023 recommendations have on the use of non-pharmacological interventions such as pulmonary rehabilitation?
I think there's been a tremendous emphasis on rehab over the past couple of years itself. It's not only with the Goal 2023, but I think even before that, there's been this increasing awareness of the fact that pulmonary rehab will produce a tremendous benefit in these patients, especially over a period of time, reduce their oxygen deficit, try and increase their exercise capacity, reduce their exacerbations, increase your exercise capacity, increase your 6-minute walk distance, and things like that. So I think the question of pulmonary rehab has to be re-emphasized again and again and again. And I think that's what Gold has done today. Gold has put another emphasis on pulmonary rehab so that we take it up very seriously and we understand the implications of that. There could be a lot of problems with pulmonary rehab. It's not that pulmonary rehab is a sort of simple walk in the park. It's not. If you take a country like India, we understand that pulmonary rehab has tremendous logistic problems and limitations. But the point that we need to understand is that you can do what is called home rehabilitation. Teach patients some simple exercises like limb exercises, strengthening exercises. Look at their nutrition, for example. Look at all the other things they can possibly do at home by themselves. And today, after the COVID, we have started tele-rehab in these patients. Ask them to attend one session of a tele-rehab, which can open their eyes as far as exercise is concerned. So they can go into all these things, and rehabilitation can be a meaningful process in these patients with COPD.
Thank you so much, sir. Thank you for answering that question. Moving to the next question that we have received, and the question is, has there been any notable changes in the assessment and management of comorbidities in COPD based on the updated guidelines?
The updated guideline is not really has sort of stressed the importance of comorbidities. Number one, and the comorbidities, we've always known that it occurs. They have mentioned a lot of things here today. For example, bronchiectasis has been given a great deal of entity, and I think it's something, especially in a country like India, with the type of infections that we have. Bronchiectasis is one of the biggest comorbidities that can occur here. Cardiovascular disease, diabetes, and obstructive sleep apnea, for example, a post-tubercular COPD, and these are entities that are very, very important. So we need to understand that there are very, very large emphasis has been placed on comorbidities in these patients.
Thank you so much, sir. Thank you for answering that question. Moving to the next question and last question for today's session before concluding it. The last question is, are there any specific updates in the GOLD guidelines related to the assessment and treatment of COPD in special populations?
No, I think if you're looking at special populations, it means, like, for example, as I said, if you take comorbidities, you start segmentalizing these patients. Like if you have a patient with bronchiectasis and COPD, for example, you try to segmentalize the bronchiectasis itself. Try to pick up the organism, try to find out what the organism is, concentrate on infection prevention, concentrate on chest physiotherapy, concentrate on vaccination, for example, pneumococcal and influenza vaccination, where you look at infections in these patients, where infections are the basic sort of thing. So they open up this entity for you. Whereas on the other hand, if you're looking at a smoking COPD patient, you concentrate on taking the smoking off and trying to practice smoking cessation in these patients. If you have patients with COPD who are occupational, for example, who have occupational inhalation therapy, for example, occupational inhalation producing COPD, you look at the occupational pollutants that you're looking at and try and look at these entities as such. And as I said, 90, more than 90% of these patients will have one comorbidity or the other. And I think the treatment of that one comorbidity and make that one comorbidity meaningful as far as treatment is concerned will go a huge way in benefiting patients and making their lives better, so they can live more better and more effective lives than before.
Thank you so much, sir. Thank you for answering that question for our viewers and for making them understand the topic better with all your answers. I would also like to thank all our viewers for their ardent participation that they have shown on our platform by staying tuned with us and for their patient listening throughout the session. So thank you to all of them. And at the outset, I would also like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights with our viewers and for making them understand the topic better. So thank you so much, sir. Thank you for all of it.
Thank you.
And I would also like to wish everyone a very happy new year in advance. We are one day to go to step into the new year. So I hope this new year brings joy and happiness for everyone and, of course, a good health. May we all be protected from the new COVID variant. So yeah, thank you.
Thank you very much and a happy new year to one and all. Thank you very much. Very pleasant talking to you. Thank you.
Thank you so much, sir.
Thank you, ma. Thank you. Thank you. Thank you.